So spleen, it is coming from spleen in Greek word and lien in Latin. Okay, this lien is used during description of different ligaments, linorenal ligament like this. Okay, line means spleen. So spleen is the largest lymphoid organ of the body. It is considered as the hemolymphoid organ as it performs these functions. It helps in removal of worn out old RBCs by phagocytosis, hematopoiesis during the fetal life, and lymphopoiesis throughout the life. So these are the main functions of the spleen. Other functions are immune response by production of lymphocytes under antigen stimulation and production of plasma cells which produce antibodies. It also phagocytosis of microorganism occurs in the spleen and it acts as a reservoir of RBCs, okay, in the red pulp and sinusoids. Under some circumstances, the hemopoiesis function of spleen may restart in the adult life. Generally, hemopoiesis occurs in fetal life in the spleen. And these conditions include chronic myeloid leukemia and myelosclerosis, generally cancerous conditions. Okay. Next is pitting of RBCs. The splenic macrophages can remove inclusion bodies from abnormal RBCs without destruction of RBCs. Example is removal of hinge bodies formed due to altered hemoglobin. Okay, and spleen stores RBCs that gets released into the circulation when needed. When there is rapid blood loss, spleen contracts and release some amount of blood into the circulation. What is the location? You can see this represents the location. This is posterior view from the posterior aspect. Okay, you have seen in the cadaver spleen is present posteriorly near the ribs. Okay, posterior part of the ribs. This is mid axillary line, and you can see the spleen is lying against 9th, 10th, and 11th rib. Okay, so you during holding the spleen you place these three fingers against the spleen. Okay, this three finger will represent the three ribs and 10th rib represent the axis of the spleen. Okay, and anterior end is directed laterally forward and slightly downward. Okay, so this will be the anatomical position I will show you at the end. So spleen is situated in the left hypochondrium and partly in the epigastrium. Lies as a wedge in between the fundus of the stomach and the diaphragm. What is the axis? Long axis of spleen. It is directed downward, forward and laterally and it coincides with the left 10th rib, 10th হবে, okay? The axis is formed by 10th rib and long axis of spleen makes the angle of about 45 degree with the horizontal plane. Okay, and spleen lies opposite 9th, 10th and 11th of it. Okay, 9th against 3 ribs, 9th, 10th and 11th rib behind the mid-axillary line under the diaphragm. So this is the summarization of external feature. It is largest lymphoid organ located in left hypochondrium and epigastrium, lies against 9th, 10th and 11th rib. Axis coincides with 10th rib and makes an angle of 45 degree with the horizontal plane. Okay, and size and shape, it is wedge shaped or tetrahedral, soft organ, purple in color. Okay, and you see there is one Harry's dictum. This is asked in your viva table, Visara. Okay, Harry's dictum of odd numbers. You can see thickness of spleen is 1 inch, breadth is 3 inch, length is 5 inch, weight is 7 ounce, and spleen lies against 9 to 11th rib. Okay, only even number used is 10th. 10th rib acts as the axis of the spleen. So all these measurements of the spleen coincides with the odd numbers. Okay, so this is known as odd Harry's dictum of odd numbers of spleen. Okay, so external features, spleen has two ends. inferior pole or anterior end. Anterior end is lying slightly inferiorly, and as a posterior end or superior pole, and two borders, antero-superior border, posterior-inferior border, two surfaces, superolateral surface and inferolateral surface, and a hilum of the spleen. Okay, so it has two surfaces, superolateral and inferolateral, and has a hilum. So anterior-superior border may have one or two notches near its inferior pole. Okay, that's how you identify anterior-superior border. Anterior-superior border have notches, and these notches are developmental in origin. Okay, this is also asked in your viva, why notches are present in the anterior-superior border of the spleen, or how will you identify this border with the help of these notches. See here, this is the location. V from anterior aspect, 10th rib forming the axis, long axis, and spleen is lying against 9 to 11th rib. Okay, and forming an angle of 45 degree with the horizontal plane at the level of T10. So spleen has these following features. It has two poles. Inferior pole is broad pole, superior pole is blunt pole. Okay. See here, inferior pole or anterior pole, this is broad, and posterior pole is pointed or blunt. Two borders, thin and convex, antero-superior border, and that has one or two notches, and rounded posterior-inferior border. Here you can see this is antero-superior border, it has some notches, and this is posterior-inferior border. And two surfaces, superolateral or diaphragmatic convex smooth surface, and inferomedial or visceral concave surface. It is irregular surface, and that has hilum of the spleen. Okay, so this which is lying against the diaphragm and ribs, that is the diaphragmatic surface, and this surface in which the visceral are relating, that is visceral surface. Okay, and here in the middle part, this white area represents the hilum of the spleen. Okay, so now we are discussing the superolateral diaphragmatic convex smooth surface and inferomedial visceral concave irregular surface. It has the hilum of the spleen. Anatomical position, hold the spleen in the left palm in such a way that it convex smooth diaphragmatic surface faces posterolaterally and to the left, and its broad inferior pole is directed downward, forward and to the left, and rounded superior pole is directed upward, backward and to the right. Okay, so this is anterior pole is directed downward, forward and to the left, and posterior or superior pole is directed upward, backward and to the right. The antero-superior border has one or two notches appear at its anterior end, and you have to tilt the palm so that long axis of spleen lies against the middle finger, and it should take an angle of 45 degree with the horizontal plane. So we are going to size, shape and color. It is wedge shaped. It may be tetrahedral or triangular in shape. It is a soft organ with purple color, and the size of spleen roughly corresponds to the first of the subject. Okay, and these are the measurements: length, breadth, thickness, weight. Okay, this is in semi, this is in inches and ounce. Okay, so thickness is 1 inch, breadth is 3 inch, length is 5 inch, and these are the corresponding centimeters, and weight is 5 ounce, and in gram 150 gram. Okay, so Harry's dictum you remember, from that you can calculate these measurements. So spleen is a highly vascular, friable, elastic, purple colored organ, and it has this following presenting part: two ends, anterior extremity or inferior end, posterior extremity or superior end, two borders, superior and inferior border, two surfaces, superolateral surface, inferomedial surface with hilum. See, this is the superolateral surface or diaphragmatic surface. It is smooth and convex. It is anterior end, broad end or inferior pole, and this is superior pole or um, posterior end. Okay. This is antero-superior border or superior border. It has notches. Posterior-inferior border or inferior border does not have any notch. Okay, and these are two angles are present at the anterior end. It is anterior basal angle, and this one is posterior basal angle. That is also asked. Okay, and this is visceral surface. It is irregular, comes in relation to different viscera. Okay, so at here it is colic impression. Here this is gastric impression. Here is renal impression, and here at the hilum lies the tail of the pancreas, and small part have pancreatic impression. Okay, and these are the splenic vessels. These are entering through the hilum of the spleen. So this part related to stomach, here with the colon, left colic flexure, and here with the left kidney. Okay, the schematic diagram. These are the splenic vessels entering through the hilum, antero-superior or superior border, posterior-inferior border, anterior end or inferior pole, superior pole or posterior end. Okay, this is anterior basal angle, posterior basal angle. And this is a section, coronal section through the spleen. This is the diaphragmatic surface, and this is the visceral surface, and here is the hilum. Two borders have been shown. This is antero-superior or superior border. This is posterior-inferior or inferior border. And sometimes near the hilum, a ridge-like structure is considered as intermediate border. Mainly two borders, you say. Okay, so these are the terms used for description of spleen. End of the spleen. Anterior extremity is the posterior end. Okay. Two ends, anterior and posterior extremity, the previous terms. Okay, and these are the anterior end, posterior end, two borders, superior, inferior, sometimes considered as intermediate border, that is a ridge-like structure. Okay, and two surfaces, lateral or diaphragmatic, medial is visceral. And these terms sometimes used. Lateral is considered superolateral. Medial is considered inferomedial. Others are almost same. Okay, so anterior extremity, it is broad and expanded, looks like a border, and it is directed downward, forward to the left and reaches up to the mid-axillary line. Posterior extremity is rounded and blunt and directed upward, backward and to the right towards the vertebral column. Two borders are superior border, inferior border. Superior border separates diaphragmatic surface from gastric impression of the visceral surface. It is convex near its anterior end. It has one or two notch. An inferior border separates the diaphragmatic surface from renal impression of the visceral surface, and it is rounded than the anterior-superior border. According to previous concept, intermediate border separates the gastric impression from the renal impression. And two surfaces are diaphragmatic or superolateral surface. It is smooth convex, faces superolaterally. Visceral or inferomedial surface, it is irregular, faces inferomedially towards the abdominal cavity. And hilum lies at the visceral surface between the gastric and renal impressions, and it gives passage to branches of splenic vessels. Okay, and two angles at the anterior extremity, it has two angles and it looks like a border. So anterior basal angle, it is a junction of superior border with the anterior end of spleen, and on splenomegaly it becomes palpable, hence called clinical angle of the spleen. That's why these angles are important. And posterior-basal angle is the junction of inferior border with the anterior end of the spleen. Okay, next we are going to relations of the spleen. First, the peritoneal relations that will form different ligaments. Okay, spleen is entirely covered by peritoneum except at its hilum, and thus it is suspended by these following folds of peritoneum or peritoneal ligaments. First is gastrosplenic ligament. Gastro means stomach and spleen, so it is connecting the spleen with stomach. So it extends from hilum of the spleen to the upper part of greater curvature of the stomach, and it contains the short gastric vessels, lymphatics and sympathetic nerves. Next is linorenal ligament, extends from hilum of the spleen to the anterior surface of left kidney, and it contains the tail of pancreas, splenic vessels, pancreatico-splenic nodes and sympathetic nerves. Next is phrenicocholic ligament. It is a triangular fold of peritoneum that extends from left cholic flexure to the diaphragm, opposite the left 10th and 11th ribs. It supports the inferior pole of spleen from the lower side, and it is called sustentaculum linis. Okay. Here you can see the peritoneal relations. Okay, stomach have been removed. This is the gastrosplenic ligament connecting the stomach. These are the two ends of the stomach. Here is the cardiac end, here is the pyloric end. Okay, so this is gastrosplenic ligament. And linorenal, okay, here phrenicocholic have been shown. Okay, phrenicocholic is connecting the left cholic flexure with the spleen. And here is the linorenal. Both gastrosplenic ligament and linorenal ligament are continuous with each other near the hilum of the spleen. Linorenal is connecting spleen with the kidney. Okay, so these are the main ligaments. Here, this diagram you practice. Okay, you can see here. This is linorenal ligament, and you can see tail of pancreas is reaching the hilum through this linorenal ligament along with the splenic artery. Okay, and this is gastrosplenic ligament. Here passes the short gastric artery. Through it passes short gastric artery, which are branched from splenic artery, supplying the fundus of the stomach. Okay. Okay, and here is the kidney and the spleen. This is cross section through the stomach, spleen and kidney. So these are the relations. Peritoneal relation. Intraperitoneal attachments are gastrosplenic ligament, linorenal ligament, phrenicocholic ligament. Visceral relations are also there. Diaphragmatic or visceral surface. It comes in contact with diaphragm, left lung and left pleura sac, left costodiaphragmatic recess in the lower part, and left 9th, 10th and 11th ribs. Okay, all these structures are related. Next is visceral surface. Visceral surface related to fundus of the stomach, gastric impression, anterior surface of left kidney, renal impression, left cholic flexure, cholic impression and tail of pancreas near the hilum. Okay, and this is the clinical aspect. Movement of spleen occurs in case of enlargement. It occurs anteriorly. It is enlarged anteriorly, and splenomegaly occurs in some disease conditions, thalassemia and other patients, and splenectomy is done. Okay, in case of thalassemia, if there is some crisis occurs, there is destruction of RBCs, because RBCs are deformed in the thalassemia patient. So when they passes through the splenic circulation, they get destroyed. Okay, so to prevent this destruction, splenectomy is done. Or in case of any splenic rupture during road traffic injury, you have to do splenectomy. Splenic puncture is done for any biopsy or something. Splenic infarction is also common. So you have to know the blood supply. Okay. And splenic sequestration occurs in sickle cell anemia. Okay. The blood cells are sickled and they will block the micro vessels in the spleen. That is known as splenic sequestration. And as splenia, there is no development of spleen. Patient will not have any spleen. Okay. So gastrosplenic ligament separates the lesser sac from the greater sac, and pedicle of the spleen is formed by gastrosplenic and linorenal ligaments together, okay, near the hilum. Phrenicosplenic or linophrenic ligament, it is a upward continuation of the linorenal ligament that suspends the hilum of the spleen with the diaphragm. Hence, it is also called suspensory ligament of the spleen. It suspends the spleen from the diaphragm. And phrenicocholic ligament is also called Hensing's ligament, according to this name of the scientist, German scientist. Next, these are the relations you see. Relations of diaphragmatic surface. Relations, first it comes in contact with diaphragm. Okay. Then the lower end of left lung and the left pleural sac, and the left costodiaphragmatic recess in the left part, and 9th, 10th and 11th ribs and their intercostal spaces. So these are the relation of diaphragmatic surface. You can see from the diagram. This is phrenicocholic, okay, connecting the left colic fracture with the diaphragm. This prevents anterior displacement of the spleen. Next, visceral relations. Here is the gastric impression related to fundus of the stomach. Visceral relation is asked in your viva. Very, very important. So, this is gastric impression related to fundus of the stomach. Here, anterior surface of left kidney. This is renal impression, comes in contact with anterior surface of left kidney. Left colic flexure. This is colic impression. Here lies the left colic flexure. Tail of the pancreas, this area near the hilum comes in contact with tail of pancreas. These viscera produce gastric, renal, colic, pancreatic impression respectively. Okay. So like this diagram, you can practice gastric impression, colic impression, renal impression, pancreatic impression, hilum, anterior angle, posterior, anterior end, posterior end. Okay. So gastric impression is a broad concave impression lies between anterosuperior border and hilum of the spleen and produced by fundus of stomach separated from stomach by greater sac. Renal impression is shallow concave impression situated between hilum of spleen, posterior inferior border, produced by left kidney. Colic impression is flat impression at the inferior or anterior pole of spleen. It is related to splenic flexure of colon and it is supported by phrenicocholic ligament. And hilum of the spleen is pierced by splenic vessels, autonomic nerves and lymphatics. Next we go into the clinical aspects. This is palpation of the spleen. Okay, you have to learn it during your final year medicine. Okay, in second year also you will learn gradually. So the anterior pole of the spleen is prone to injury in blunt abdominal trauma or during some surgical procedure. During surgeries, excessive traction of the stomach, transverse colon and greater momentum should be avoided because it may cause tear of splenic capsule and bleeding. Okay, spleen is highly vascular organ, so if any tear occurs, there will be heavy bleeding. Movement of spleen. Spleen is intraperitoneal structure related to diaphragm. Hence, the spleen moves with respiration. Okay. Palpation of spleen. A normal spleen is not palpable, but when spleen enlarges more than double in size, it becomes palpable at the left costal margin during deep inspiration. Okay, so you have to tell the patient to take a deep breath. After that, you palpate for the spleen at the left hypochondrium. Splenomegaly. See, this is the direction of splenomegaly towards the umbilicus. Then it is directed to right iliac fossa. This arrow represents the direction of splenomegaly. Here is the normal position, it gradually increasing in size. Splenomegaly is enlargement of spleen. Enlarged spleen project toward the right iliac fossa in the direction of axis of 11th rib, and it occurs because of immunological or hematological causes, such as if abnormal RBCs occur in thalassemia, sickle cell anemia, these patients you will get splenomegaly. Immune disorders and infection like in malarial infection, splenic abscess, typhoid fever, rheumatoid arthritis, in these also mild enlargement of spleen occurs. Cancerous condition, leukemia, in this case huge enlargement will occur. Obstruction of venous blood in cirrhosis of liver, obstruction of portal vein, all these can lead to splenomegaly. Okay. Moderate amount of enlargement occurs in cirrhosis and obstruction of portal vein. Next is splenectomy. When you will do it, it is a surgical removal of spleen. It indications are injury to the spleen, some cancerous conditions like leukemia, severe hemolytic anemia, and so on. Hemolytic anemia is thalassemia, sickle cell anemia, all these included in hemolytic anemias. Patients after splenectomy do not respond appropriately to the infection. So, after splenectomy, operation due to rupture of intra-abdominal injury, patient develop diabetes mellitus because of accidental removal of tail of pancreas. This comes in your explain why. Why after splenectomy, patient develop diabetes mellitus? Because sometimes during splenectomy, tail of the pancreas is removed, and tail of the pancreas contains maximum amount of islets of Langerhans. Contain insulin secreting beta cells are present in the islets. So most of the insulin producing islets of Langerhans are located in the tail of pancreas, and that is removed during splenectomy. So there is chance of development of diabetes mellitus. This is very frequently given explain why question. Why after splenectomy diabetes mellitus develops? Okay. Next, we are going to blood supply, lymphatic drainage, and innervation. Spleen is supplied by splenic artery, which is the largest branch of celiac trunk. It is one of the most tortuous artery in our body and allows movement of the spleen. Okay. Splenic artery passes behind the stomach along the superior border of body and tail of the pancreas. This relation is important. Okay. Splenic artery you have to identify. It is a tortuous artery and lies along the superior border of body and tail of the pancreas and enters through the hilum of the spleen. And it passes through the linorenal ligament, that is asked in your viva and MCQ, through which ligament tail of the pancreas is passing. And at the hilum of the spleen, it gives 4 to 5 branches for the spleen. See here, this is the celiac trunk, splenic artery arising here, giving branch to the pancreas. One branch is large, that is arteria pancreatica magna, lying along the superior border of body and tail of pancreas, and near the hilum it is dividing into 5 to 6 branches. Okay. Next we are going to venous drainage. Splenic venules run in trabeculae and join to form smaller veins that converge at hilum as 4 to 5 veins, and these smaller veins join to form the splenic veins. These smaller veins, these are joined to form the splenic vein, and the splenic vein run horizontally behind the body of pancreas. This is splenic vein. This is straight, this is not tortuous. Okay, so that's how you differentiate splenic artery and splenic vein. Splenic artery lies along the superior border of pancreas, and splenic vein lies posterior to the pancreas. Locations are also important for identification in viscera, and it joins with the superior mesenteric vein. This is superior mesenteric vein to form the portal vein behind the neck of the pancreas. This is neck. So this is head of pancreas, this is uncinate process of pancreas, body of pancreas, tail of pancreas. Okay. Okay, next we are going to lymphatic drainage. Lymphatic drainage begins in the white valve, and lymphatic vessels pass towards the capsule to open into the subcapsular plexus, which converge at the hilum and drain into pancreatico-splenic nodes located in the hilum of the spleen. And these lymph nodes finally drain into the celiac nodes. According to previous concept, proper splenic tissue has no lymphatics, only trabeculae and capsule of the spleen have lymphatics. Next, we are going to innervation. It is a viscera, so autonomic innervation is there, sympathetic and parasympathetic supply. So, sympathetic fibers from the celiac plexus supply the blood vessels and a small number of smooth muscles in the capsule of the spleen, and they regulate the blood flow to the spleen. And the sympathetic fibers carry pain sensation, and parasympathetic fibers from vagus nerves passes through the splenic vessels passes along the splenic vessel and will supply the spleen. That we have already discussed. Splenic circulation very important for theory. Okay, we have whole lecture we have discussed splenic circulation. You prepare long question for theory. Okay, so blood flow of the spleen is 7% of the cardiac output, and in some animals, the capsule of the spleen contain large number of smooth muscle fibers, and on stimulation, these fibers contract and release blood from the spleen into the circulation. And splenic vascular segments, this is also vast. Okay, so before entering the spleen, the splenic artery gives superior and inferior branches, and these branches do not anastomose in the spleen. Hence, a avascular zone exists between these territories of these two arteries, and thus spleen has superior inferior segments separated by avascular plane passing perpendicular to the long axis of the spleen, and it can be used for segmental resection of the spleen. And the spleen may be diffuse or compact based on branching pattern of the splenic artery. In diffuse type of spleen, terminal branches of splenic artery arise from the hilum, whereas in compact type of spleen, they arise near the hilum. Histology, you will be discussed in histology. Development of spleen, not much important. It will be discussed in lecture. Okay, lecture হয়েছে development আজ start হয়েছে. Okay, so these are related to the development. Okay, accessory spleen, lobulated spleen. Okay, these are development related clinical aspects. Splenic puncture, these are some clinical aspects. Spleen can be punctured using lumbar puncture needle for measurement of intrasplenic pressure or splenic venography. And for splenic puncture, needle should be passed through 9th or 10th intercostal space in the mid-axillary line, and ask the patient to hold the breath to avoid injury to the spleen during the procedure, laceration. And splenic infarction, it condition of compromised blood supply to the spleen. Silence. Splenic infarction is a condition of compromised blood supply to the spleen, as the branches of splenic arteries are end arteries, and their occlusion by emboli causes splenic infarction. What is Kerr sign? It is the classical symptom of the ruptured spleen. It is the occurrence of acute pain in the tip of shoulder due to presence of blood in the peritoneal cavity. Okay, it will irritate the diaphragm, and nerve supply is common for diaphragm and the shoulder. Okay, and root value C3, C4, and nerves involved are phrenic nerve and supraclavicular nerve. Okay, that is also important. Kerr sign is asked when explain why. Okay, why in case of rupture of spleen there will be pain in the shoulder. Okay, because of common nerve supply. C3, C4 root value is involved. This is supplies the diaphragm through the phrenic nerve and supplies the shoulder area through supraclavicular nerve. Okay, that's why I explain why question is important. And Kerr sign, this pain, it is also seen in ruptured spleen, also in some renal calculi, and in subdiaphragmatic abscess. Okay. Sickle cell anemia. The splenic sequestration crisis is a life-threatening condition, occurs mostly in sickle cell anemia and beta thalassemia due to vasoocclusion and trapping of large quantity of blood in the spleen, and it may cause hypovolemic shock and death in the patient. In long term, small repeated splenic infarct produce scarring and fibrosis of the spleen. Next is asplenia is absence of splenic function, may be due to congenital or surgical removal of spleen, and it may also be due to destruction of spleen in sickle cell anemia and thalassemia, and causes of asplenia are prone to severe infection. Okay, so patient have to be careful after this removal of spleen. Immunity is lost. So hyalosclerosis is deposition of fibrous hyaline coat over the spleen. Sugar coated spleen. Liver is also sugar coated and heart frosted in this condition. Okay, hyalosclerosis. So next we are going to the pancreas. We have completed spleen. Pancreas is a soft lobulated gland. It has both exocrine and endocrine function. Exocrine part secretes. So it is a mixed gland. Pancreas is a mixed gland. Okay. Liver is also a mixed gland. So exocrine part secretes digestive pancreatic juice that enters the second part of duodenum through pancreatic duct, and the endocrine part of pancreas secretes hormones directly into the blood. For example is the insulin. Okay, other hormones are also released, glucagon, somatostatin. These are also released from the islets of Langerhans. What are the functions of the pancreas? It performs exocrine function. It secretes alkaline pancreatic juice, and that contains these following chemicals. Bicarbonates neutralize the acidic content of stomach that enters the small intestine, and pancreatic enzymes, they digest the food material. For example, proteases, protein breaking enzymes, trypsin and chymotrypsin, they digest proteins. Amylases, they hydrolyze the carbohydrate, and lipases break the lipids. All these are present in pancreatic juice. Okay. Endocrine function, islets of Langerhans secrete insulin, glucagon, somatostatin, and pancreatic peptides. Location of pancreas, it is lies more or less horizontally across the posterior abdominal wall from the concavity of the duodenum to the hilum of the spleen, and it lies at the level of T12 to L3 vertebra. Okay, it lies in the epigastric, umbilical, left hypochondriatic regions, and most of the pancreas is retroperitoneal except its tail that extends into the linorenal ligament. Due to the deep location along the posterior abdominal wall, the pancreas is not accessible for physical examination. From anterior aspect, you cannot examine it. You have seen the location in the cadaver yesterday. Okay. Next is size, shape, and color of the pancreas. Pancreas is creamy pink, soft to firm in consistency, and has finely lobulated surface. It is a J-shaped or retort-shaped organ. Here you can see J-shaped or retort-shaped organ, pancreas. Okay, it has lies obliquely on the posterior abdominal wall, and it has four parts. It has a head, neck, body, tail. Okay, so this part is head. Here is the neck, body, and the tail. Length is about 12 to 15 centimeter. Width is 3 to 4 centimeter. Thickness is 1.5 to 2 centimeter. Weight is 80 to 90 gram. Volume is 70 to 80 cc. Okay. So the measurements of pancreas. See here, this part lying within the curve of duodenum. This is head. Junction between head and body is the neck. This is body, and this part is tail. Okay, and this process you can see, this is the uncinate process of pancreas. Okay, this is the duodenum, first, second, third, and fourth part of the duodenum. Here is the duodenojejunal flexure. This is fourth part, very small part. Here, through the hilum of the spleen, tail is entering through the linorenal ligament. Okay, so this is the different regions, umbilicus. So here is the location of pancreas. You can see here, opposite T12 to L3. Okay. So pancreas lies across posterior abdominal wall T12 to L3. Retroperitoneal occupies epigastrium, umbilical, left hypochondrium. Epigastrium, umbilical, left hypochondrium. These are the location of pancreas. The size and shape, it is creamy pink, consistency soft to firm, finely lobulated, J-shaped, length 12 to 15 semi, width 2 to 4 semi, thickness 1.5 to 2 semi, weight is 80 to 90 gram. Parts are head and uncinate process, neck, body, tail. Okay. Presenting parts you have to show in the viscera. So pancreas is draped over the vertebral column and other retroperitoneal organs, and the volume of pancreas increases with age, reaches its maximum in the fourth decade and decreases after the 60 years. Fourth decade means after 40 years it increases size up to 40 years. So this is head, neck, body and tail, and you can see the superior mesenteric vessel passes behind the neck of pancreas, but it passes anterior to the uncinate process. Okay, this relation is important. So pancreas is divided into four parts from right to left. Head is the enlarged part that lies in the concavity of duodenum. Neck is slightly constricted part. Body is elongated. Tail is narrow pointed part that reaches the hilum of the spleen. Next we are going to the peritoneal relations. Ventral surface of pancreas is covered by parietal peritoneum and it is crossed by the root of the transverse mesocolon. The tail of pancreas is its only intraperitoneal part and lies in the linorenal ligament, and pancreas lies posterior to the lesser sac. Head, uncinate process, neck, body, tail. And this projection from the body upward, that is known as tuberomental of the pancreas. It lies opposite the tuberomental of the liver. Okay. And the loose connective tissue that lies posterior to head of pancreas is called fission fossa of Treitz, and that lies posterior to body and tail of pancreas is called fission fossa of Tolt. Okay. Head of posterior, fission fossa of Treitz. Body and tail posterior, fission fossa of Tolt. The important pancreatico-duodenal arcades of arteries and veins are situated in these fossa. Okay. Next, we are going to discuss the head in details with its relations. Head is involved in different disease conditions mainly. Okay. So, head of pancreas is enlarged disc-shaped right end of pancreas. It lies in the concavity of C-shaped curve of duodenum. কে কথা বলছিস কন্টিনিউয়াসলি? তোরা উঠাই, সামনে উঠাই, তোদের দুজনকে বলছি। হ্যাঁ, কি এত কথা আছে? যা জিজ্ঞেস করার ক্লাসে পরে করবি। The head of pancreas is enlarged disc-shaped right end of pancreas lies in the concavity of C-shaped curve of duodenum in front of L2. These are the external features. Head has three borders: superior border, inferior border and the right lateral border. Two surfaces, anterior and posterior, and one process is the uncinate process. So uncinate process is a hook-like projection at the lower end and left part of the head and projects towards the left side. These are the relations of different borders. Superior border is related to first part of the duodenum here. This is superior border of head related to first part of duodenum, superior pancreatico-duodenal artery. Inferior border, it is related to third part of duodenum, inferior pancreatico-duodenal artery. Right lateral border, this is right lateral border related to second part of duodenum, terminal part of bile duct. Anastomosis between the two pancreatico-duodenal arteries. All these three are related to the right lateral border. এই যে এখানে দেখ bile duct, pancreatico-duodenal artery দেখায়নি। Okay. Anterior surface is directed forward and to the right. Okay. and it is related from above downward to first part of duodenum, transverse mesocolon. The blue structure is transverse mesocolon, transverse colon, jejunum, and posterior surface is directed backward and to the left related to the bile duct, inferior vena cava, terminal part of the renal veins, right crus of the diaphragm. Okay, this is the right crus have been shown here. And relation of uncinate process, it is a triangular hook-like projection from lower part of the head related anteriorly to the superior mesenteric vessels and posteriorly to the abdominal aorta. Okay. So these are the head of pancreas, enlarged disc-shaped right end of the pancreas. It has these borders, superior, inferior, right lateral border. Superior border is related to this first part of duodenum, superior pancreaticoduodenal artery. Inferior border, third part of duodenum, inferior pancreaticoduodenal artery. Right lateral border related to second part of duodenum and bile duct. Anterior surface is related to first part of duodenum, transverse colon, transverse mesocolon, jejunum. Posterior surface is related to bile duct, inferior vena cava, renal veins, right crus of diaphragm. Processes is uncinate process, triangular hook-like projection, anteriorly related to superior mesenteric vessels, posteriorly abdominal aorta. And the bile duct lodges in a groove between the pancreas and second part of the duodenum, and it is often embedded in the substance of the pancreas. Inferior vena cava separates the head of pancreas from right sympathetic trunk and right psoas major muscle, and head of pancreas is the thickest and the broadest part of the pancreas. Next we are going to neck. Here is the neck. The green colored lines represent the neck. Neck is slightly constricted part, connects the head with the body. It is about 2 cm long and directed forward, upward and to the left. External features of neck, it has two surfaces, anterior surface and posterior surface, and two borders, upper and lower border. Relations of neck, anterior surface is covered by peritoneum of the lesser sac and is related to pyloric end of stomach. Posterior surface is related to superior mesenteric vein in the lower part and trunk of portal vein in the upper part. See, there is the posterior relation. Superior mesenteric vein in the lower part, portal vein in the upper part. Okay. And here is the anterior relation. It is related to peritoneum of lesser sac, related to pyloric end of stomach. Pyloric end of stomach have been shown. And upper, it has two borders, upper border and lower border. Here is upper border, lower border. Upper border is related to first part of duodenum. This is first part of duodenum, upper border. Lower border is related to root of transverse mesocolon. Okay. So neck is two semi-constricted, two surfaces, two borders and their relations. Okay. So neck of pancreas is posteriorly related to formation of portal vein. Very, very important. Everyone will be asked what structures are lying posterior to neck of pancreas. Hence, the surgical resection of pancreas is difficult in case of pancreatic cancer because of presence of this venous structures. Large veins are there will be chance of bleeding. Next, we are going to body of pancreas. Body is triangular in cross section. Okay, body of pancreas is the longest part of the gland, extends from neck to the tail, and it passes to the left and slightly upward. External features of the body. Body is slightly triangular in cross section. It has two surfaces, anterior and posterior surface. This is anterior surface and posterior surface. Okay, and two borders. And previously it was said body has three surfaces because it is triangular. This is anterior surface, posterior surface, and this part was considered inferior surface. Okay, and borders are two according to recent concept, superior and inferior border. But according to previous concept, superior, inferior border, and another anterior border. Okay. So these are the borders and surfaces. And one process is tuberomental. From the body projecting upward, it is a rounded conical elevation from right end of the superior border. Okay, so these are the relations. Superior border is related to celiac trunk over the tuberomental and hepatic artery to the right and splenic artery to the left of tuberomental. Inferior border is related to superior mesenteric vessels at its right end. And as per previous concept, anterior border provides the attachment to the root of transverse mesocolon and separates the anterior and inferior border. This is important, okay? Transverse mesocolon attached along the anterior border. So anterior surface is covered by peritoneum, gives attachment to the transverse mesocolon, and the relations above the attachment of transverse mesocolon is lesser sac and stoma. A relation below the attachment of transverse mesocolon is infracolic compartment of greater sac containing coils of jejunum, duodenojejunal flexure, left colic flexure. Okay, and according to previous concept, the above mentioned anterior surface is divided into anterior and inferior surface by anterior border, which was providing attachment to transverse mesocolon, and posterior surface is devoid of peritoneum. Okay, and it is lies on fusion fascia of told. It is related to these structures: aorta, origin of superior mesenteric artery, left suprarenal gland. Yesterday you have seen origin of superior mesenteric artery was lying posterior to the body of pancreas. Left suprarenal gland, upper pole of left kidney, left renal vein, splenic vein, which may be embedded in the gland, and left crus of the diaphragm. So these are the important relations of the body. See here, this is attachment of transverse mesocolon along the anterior border. Okay, below it lies the coils of jejunum, transverse colon, the left colic flexure, and above it lies this. Here is the tuberomental. Near the tuberomental related to celiac trunk. Right to it lies the hepatic artery. Left to it lies the splenic artery. Okay. And these are the posterior relations of pancreas. Posterior to it lies the aorta, origin of the superior mesenteric artery, left suprarenal gland, this is the left kidney, left renal vessels, left crus of diaphragm. Okay, and this is the portal vein, formation of the portal vein by joining of the splenic vein with the superior mesenteric vein. So body of pancreas connects neck with the tail. External features, it has two borders, superior, inferior. Superior border is related to celiac trunk, hepatic artery, splenic artery. Inferior border, superior mesenteric vessels. Surfaces, anterior surface related to lesser sac, stomach, greater sac, coils of jejunum, duodenojejunal flexion, left colic flexion. Posterior relation, aorta, superior mesenteric artery, left suprarenal gland and kidney, left renal and splenic veins, left crus of diaphragm. Next we are going to the tail. This is the tail lying in the lienorenal ligament. Tail is the narrowest and the most left lateral portion of pancreas. It is about 1.5 to 3.5 semi long. It lies in the suprarenal or lienorenal ligament along with splenic vessels, and it is the only mobile part of the pancreas. It contains the most significant number of islets of Langerhans. Relations of tail: anteriorly lies the lesser sac and stomach, posteriorly lies the spleen and splenic vessels. Tail is at risk of injury at splenectomy during ligation of the splenic vessels. Okay, this is important why diabetes mellitus occurs, that is explained why we have already discussed. Two ducts, these are asked in viva and MCQ. Exocrine part of pancreas is drained into duodenum by two main ducts, main duct and accessory duct. Main pancreatic duct of Wirsung begins in the tail, traverses the whole length of the gland near its posterior surface, and the diameter of this duct is about 3 mm in the head. It joins with the bile duct to form the hepatopancreatic ampulla of Vater and opens in the second part of duodenum at major duodenal papilla. Accessory pancreatic duct of Santorini begins in the lower part of the head, runs upward and medially, and opens in the second part of duodenum at minor duodenal papilla. So, main pancreatic duct, major duodenal papilla, accessory duct of Santorini, minor duodenal papilla. Okay, main duct is known as duct of Wirsung. Okay, these names are important: duct of Wirsung, duct of Santorini. This will be asked in your MCQ and viva. See here, this is the pancreatic duct, main pancreatic duct, draining in the ampulla of Vater, second part of duodenum, and this is accessory pancreatic duct, draining in the minor duodenal papilla, second part of duodenum. Here, accessory pancreatic duct. This is the main pancreatic duct. Okay, accessory pancreatic duct is draining the uncinate process and lower part of head. Upper part of head, body, and tail drained by the main pancreatic duct. And the small pancreatic ducts is joining the main pancreatic duct. There is a herringbone pattern, okay, like the bones of the herring fish, okay, fish bone. And common bile duct is joining with the main pancreatic duct near the ampulla of Vater, draining into major duodenum papilla. Okay. The main pancreatic duct begins by union of small ducts in the tail of pancreas, and throughout the course of main duct receives number of small duct at a regular interval at right angle to its long axis and creates herringbone pattern. And at the neck of pancreas, the main duct turns downward and then to the right to join with the bile duct and forms the ampulla of Vater. Major duodenum papilla lies on the posterior medial wall of the duodenum and at about 8 to 10 semi distal to the pylorus of stomach. Accessory pancreatic duct of Santorini drains the uncinate process and upper part of the head of pancreas. And this duct crosses the main duct anteriorly and may communicate with the main duct in 40% of individual. And minor duodenal papilla is located at posterior lateral wall of second part of duodenum. Next, we are going to blood supply, lymphatic drainage, and innervation. So, blood supply is important for pancreas. কি পড়বি না আর ব্লাড সাপ্লাইটা পড় তারপরে বাকি বই থেকে পড়ে নিস blood supply is it's supplied by pancreatic branches of these arteries: splenic artery, which is branch of celiac trunk; superior pancreaticoduodenal, branch of gastroduodenal; inferior pancreaticoduodenal, which is branch of superior mesenteric. Okay. Here you can see superior pancreaticoduodenal, branch of gastroduodenal; inferior pancreaticoduodenal, branch of superior mesenteric. Okay, and branch it is getting branches from splenic artery also. So blood supply, arterial supply is coming from this splenic artery, superior, inferior pancreaticoduodenal arteries, and venous drainage is by portal vein, superior pancreatic vein, splenic vein. Lymphatics are draining into pancreatico-splenic nodes, celiac nodes, superior mesenteric nodes, and pyloric nodes. Innervation is coming, autonomic innervation is there, parasympathetic and sympathetic. Parasympathetic coming from vagus nerve and it is secretomotor, okay, for the glands. And sympathetic is coming from celiac and superior mesenteric plexuses and they are vasomotor. Okay. Okay, development of pancreas is very important. You read during your embryology. And histology is also important. Okay, developmental anomaly one, annular pancreas you must read. Okay, clinical aspect, annular pancreas very important. Histology is also important. Okay, and infection of pancreas is pancreatitis. There may be acute infection and chronic infection. You will read the features during your clinics. And pseudocyst of pancreas, it is circumscribed collection of fluid containing pancreatic enzyme, blood and necrotic tissue, and it is collection in the lesser sac. may present symptoms similar to the pancreatitis and occurs as a complication of pancreatitis. Okay, pseudocyst of pancreas is important clinical aspect. And carcinoma head is also important. It compresses the bile duct, leads to obstructive jaundice. This is also important. Explain why. Why in carcinoma of head of pancreas there will be obstructive jaundice. Okay. It may cause duodenal obstruction and compression of portal vein, resulting in ascites and portal hypertension also in case of carcinoma head of pancreas.